And that also applies to how we metabolize drugs. And so we metabolize medicines in different ways dependent on our genetic makeups. This lecture tackles questions like why does someone need twice the standard dose to be effective of a particular medicine? Why does this drug work for you but not me? Why do I have side effects but you don't? Why do some people get cancer and others don't? Of course, we covered some of it during the cancer lectures. And I'm not going to talk much about that, but it's also under this umbrella. Why is anecdotal information irrelevant to your own health and treatment? We need more rigorous information, ideally based on the population level. So the questions like those led to the formulation of precision medicine and personalized medicine. So precision medicine is a medical model that proposes the customization of healthcare with medical decisions, practices, or products being tailored to the individual patient. So precision medicine is an initiative of NIH, National Institutes of Health, which is a branch of US government. Personalized medicine is a medical procedure that separates patients into different groups with medical decisions, practices, interventions, or products being tailored to the individual patient based on their predicted response of risk or disease. Personalized medicine also incorporates the idea of unique therapies for an individual. What's the difference? I can't see much difference between these two terms, so I tend to use these terms interchangeably, and this is what I expect you to do so. The things common to both, so it's more like a historical, but of course this is very recent, so it's a very recent history. But at one point of time, personalized medicine term was very popular, and then NIH came up with another term pretty much for the same thing, precision medicine. Both are used. Precision medicine is probably more popular right now. You can hear it more often than personalized medicine. For both, each patient and patient group is assumed to receive, is assumed to have unique genomic makeup, and then these treatments, first assessment, diagnosis, and then treatments and follow-ups are unique per individual because of these genomic differences. And medicine is and always has been personal because we're all different. And maybe osteopathic medicine actually understands it better than traditional medicine, because osteopathic medicine always emphasized uniqueness of each person. So this slide shows you how knowledge leads to power, in a sense, how powerful knowledge is. And this is reflected by survival of leukemias and lymphomas in correlation with the accumulation of knowledge about these conditions. So back in 1950s, we knew very little about this cancer, and that was just called disease of the blood. The distinction between leukemias and lymphomas was made in 1960s, and then in 1970s, leukemias were divided into three categories: chronic leukemias, acute leukemias, and pre-leukemias. Lymphomas were also classified into some subgroups, and then with the development of new genomics tools to analyze genomic sequences, we realized that there are many types of leukemias, and there are at least 38 leukemias types identified to date, and 51 lymphomas, and some of them are listed here. But look at how that translates into 5-year survival of patients. Now it's around 70%. In the past, it used to be like a death sentence. And of course, it's not coincidence that we have more powerful ways to treat it, because we know so much more about these conditions. Don't worry about these ICD codes, international disease codes. It's something that you will see in the medical program, but it's obviously not required here. It's just to give you heads up that there is something like that you will need to pay attention to soon. This slide summarizes other benefits of precision medicine to patients. This myelogenous leukemia, we talked about that. There's a dramatic increase in 5-year survival rate, mostly due to the introduction of imatinib, which is a targeted therapy. There is a 15% increase in colorectal cancer survival, and this is following discovery of molecular receptors associated with tumor growth. For heart patients with cardiac problems, the hospitalization rate decreased by 30%, mostly due to documented. It's mostly documented when genetic information was used in dosing warfarin, a drug that we're going to talk about in a moment. Needless to say, precision medicine is very important for cancer treatment, because it customizes cancer treatment, and you saw how variable cancers are, and this is the major challenge with cancer, that pretty much every cancer is different. Even within a patient, we saw that different metastatic lesions can be genetically different. So that's a huge challenge that we face, and the precision medicine does provide new tools in addition to the standard ones like radiation, chemotherapy, and surgery. Now we have a genetic test based on gene sequencing. We can locate cancer, like new cancer causing genes, and then new types of therapy like immunotherapies can be designed, and those are designed to customize treatment per patient. It's supposed to boost the immune system in response to cancer, that again is unique per patient. And finally, it leads to new targeted therapies, new drugs that are specific to a genotype. And the great thing about these individual drugs, these personalized drugs, is that they minimize side effects of treatment compared with radiation and chemotherapy. So this is how pharmacogenomics and pharmacogenetics were also funded, because that's about drugs that are tailored toward a specific patient with specific genetic variant. So it's a new branch of pharmacology. This is a study of effects of genomic variations that have on drug response. We develop drugs that are tailored to a genetic makeup. There's a better understanding of individual or population or ethnic differences. Genetic genomics measurements are used for to make drug prescription decisions, including response or non-response, side effects, and dosage. The main goal of this new branch of pharmacology is to maximize drug effectiveness and at the same time limiting drug toxicity based on the individual's genetic makeup. Genetic information is routinely integrated into decisions regarding cancer, chemotherapy, and treatment for immunodeficiency, virus, and drug resistance infectious agents. There is, of course, there's lots of information about antibiotics and resistance of bacterial strains to antibiotics, so you can think of it also as a kind of precision medicine that takes into account bacterial genotype and genomic information. Drug metabolism, when you look at that, is very complex, and it involves multiple steps, starting with intake, absorption, leading to distribution, drug-cell interaction, breakdown, and excretion. All these steps are controlled by proteins, by enzymes, and we can see genetic variation within each of them. So each of these steps can be controlled genetically, and we can see some variation from patient to patient, how they react to the same drug. So polymorphism is observed in genes encoding drug metabolizing enzymes, drug transporters, drug targets. They can influence drug effects and contribute to this observed inter-individual differences in drug response. Now, with respect to what exactly which part of the pathway is affected by genetic variance, we sometimes make the distinction between pharmacokinetics and pharmacodynamics. Pharmacokinetics is related to these drug metabolizing enzymes and drug transporters rather than the target itself. So you can think of this central level drug-cell interaction as the target, but distribution, breakdown, and excretion are the part of pharmacokinetics rather than pharmacodynamics, because pharmacodynamics is about the drug targets, and so that you may have some variable sensitivity to the drug. So hence this distinction between pharmacokinetics and pharmacodynamics. But to some extent, this distinction is, of course, artificial, because all these effects are concerted in a very tight manner. Here are some examples of genotype driving treatment decisions. And those are very old, so we knew about those for a number of decades now. Blood type, something that you know well. There's the ABO gene that has 6 principal alleles for European populations that determine the blood type ABO. Of course, that applies to other populations as well, but European population turns out to have 6 alleles within the system. That also applies to tissue typing. We know that it's very important during transplantations, and we're talking about tissue matching, which requires typing antigens from the major histocompatibility complex or HLA antigens for compatibility. Tissue cross-matching, which is about typing antigens that could result in tissue rejection, and that leads to also transplant compatibility decisions, including immune suppression. Other examples of genotype driving treatment decisions involve specific specific reactions to drugs. Something that was first observed in on different ethnic backgrounds. There is the famous HIV antiviral treatment with abacavir. This is an effective drug that controls HIV, of course, in combination with other drugs. But it turns out that there is a gene, HLA-B, and there is a variant of this gene that has very adverse reaction to drug, and it's really very dramatic response when this high sensitivity allele is present. That's vomiting, some neuronal nervous system complications. Some cases are as severe as that they may lead to death. So this is a drug that can be deadly if it's misapplied, if it's applied to not the right people with the right genotype. It turns out that variation of this high sensitivity allele differs between populations. You can see here on this map, this allele is especially more frequent in India and some other parts of Asia, but also among South American whites, it's relatively high, between 5 and 7%. And I mentioned this, so the second example refers to bacteria. For example, methicillin resistant Staphylococcus aureus MR assay infection is caused by a staph bacteria that became resistant to many of the antibiotics used to treat staph infections, and we need now genotyping of bacteria to find the right antibiotics, and it applies not only to staph but also to other bacteria. I mentioned cancer, and we talked about breast cancer as well. There are 4 major breast cancer subtypes: luminal A, luminal B, triple negative or baseline, and HER2 type. And the table summarizes the differences, what these subtypes really mean. So, for example, luminal A tends to be estrogen positive and progesterone positive. It's also HER2 negative. HER2 is human epidermal growth factor receptor 2. And there is a low level of this kinase 67, also known as MKI67, which is a kinase marker for proliferation. So we see that some of these subtypes grow in the presence of hormones, and that actually makes them easier to treat. Because we can apply a hormonal treatment, like for example to manipulate estrogen level in the organism. The triple negative is actually negative to all 3 hormones or receptors. And HER2 is also difficult because it's negative with respect to hormones, but it's positive with respect to the growth factor receptor. But this is all relatively new knowledge, which again contributes a lot to treatment, because now we can tailor treatment based on the responses to hormones. And so this is the idea behind new drugs that are, in a sense, pharmacogenomic, based on pharmacogenomic biomarkers. And you have some examples in this table, but by no means it's a complete table. There are more than 200 drug biomarkers as of today, and there's a huge race currently to produce more of them. And Herceptin is one. I mentioned it briefly in the context of breast cancer earlier. This is about this growth factor receptor, a drug that targets this receptor. We talked about imatinib, and it's listed here as well. Currently, it's under another marketing name, Gleevec. So as you know by now, it's a tyrosine kinase inhibitor, but its variants are used to treat not just leukemia. So this is with the Philadelphia chromosome positive, but it's also applied to treat other cancers. And one of the tables mentioned these cytochromes, so you could see that like these drugs are based on this CPY2D6 cytochrome, and this is actually a very important one. So those are cytochrome enzymes. And this is a superfamily of iron containing hemoproteins that account for as much as 75% of all drug metabolism. There are 57 different active genes within the system, organized into 17 different families. And there are some examples here. You don't need to remember them all, but I'd like you to be aware of these two, CYP2C9 and CYP2D6. And the first one, CYP2C9, is responsible for metabolizing these non-steroid anti-inflammatory drugs like ibuprofen, naproxen, and so on. It's also responsible for these ARBs, which is hypertension drugs, angiotensin 2 receptor blockers like losartan. Losartan now there's a new one, telmisartan, and also warfarin that I'm going to talk about. I don't know if today, because we're running out of time, but these two not these two. This CYP2D6 cytochromosome is very important in codeine metabolism, and codeine is commonly used is an opioid. It's a prodrug, which means that it needs to be metabolized into morphine for activity. And this cytochrome gene CYP2D6 is the metabolizing enzyme that digests codeine, transforming it into morphine. And so there's genetic variation within this cytochrome. Turns out that 7% of Caucasians are missing one copy of the cytochrome CYP2D6 gene, which means that codeine does not work effectively in these individuals compared with those who have both copies of the gene. So this is the codeine metabolism. As you can see, codeine, so this is the major transformation. Codeine has to be transformed into morphine to be effective, to work as a drug. And it undergoes demethylation. So this is basically the process that takes place here. This is demethylation of this codeine conducted by this cytochromosome. I'm sorry, for the CYP2D6. And turns out that only between 5 and 10% of codeine is metabolized into morphine. There are some other transformations that take place and transform codeine into non-active compounds. So these metabolites are presumed to be mostly not active. So that's pretty much all you need to know from this slide. That basically the codeine metabolism is complex, but the most important part, if from the point of view of pharmacology, is the pathway leading to morphine, and it's controlled by this CYP2D6 enzyme. Okay, and some slides that I will get back to next week just to finish this part. Any questions?